شغال يا ابو عبد الله شغال.
اسمع جيبوا ورقه. وين هنا الشباب؟ مين هنا؟
اول واحد انا اول ترجيس.
فوزيه. مين هنا؟ فوزيه.
The second one, yeah. I will give you an idea about everybody. I got their names. I will tell you. I will tell you before. Yeah, okay. Take care of this. رهاب نبدي ولا نبدي؟ Okay.
Please to take your seats, please. We are starting the session.
Okay. Hello. Good afternoon, everybody. Unfortunately, this will be the last session for our valuable conference. Let me express my feeling about this conference in the last session. I consider this conference is very valuable and important for the people and surgeons of Gaza. I would like to appreciate all the people who participated in this conference. I'll highly appreciate the people who sponsored this conference, people who organized this conference, and people who participated in the conference. I hope we will continue to have conferences like this because the people of Gaza deserve to have all the new techniques and the new methods taking care of patients, especially in our chronic emergency situation in which we are living. Let us introduce our first speaker, Dr. Orhan Alam Oglo. He is the Professor of General Surgery, Head of the General Surgery Department at Madinat University, and he is the head of the conference. Please, Dr. Orhan.
Dear President and dear colleagues, I want to speak to you about the step wounds, only step wounds. Stem wounds, before 1960, as a general surgeon, we did routine laparotomy for penetrating abdominal trauma. Sometimes I say step wounds, sometimes I say penetrating. This means step wounds, not another trauma. 6 years ago, I started in another training and research hospital in Istanbul. At that time, 20 surgeons worked at this hospital, and the routine in this hospital, our colleagues, they did routine laparotomy for step wounds. 6 months, we did one algorithm, and 6 months all our team worked with this algorithm. After 6 months, we implement the algorithm in our clinics. Now today I want to share with you this algorithm and the result of this algorithm. When any patient come to the emergency department, we check, we have to know 3 things. This patient stable or unstable, or sometimes stable, but there is uncertain findings of peritonitis. The management of these 3 groups is different. If the patient stable, we will check the region of the trauma. This is also important because every region of the abdominal injury has a different result. If the patient is stable, this will be thoracoabdominal trauma or anterior trauma and posterior trauma. The management different. If the patient has thoracoabdominal trauma, we follow up the patient 24 hours with the physical examination, blood test, if necessary CT and gastroscopy. If the patient has anterior trauma, we do local wound exploration. There is penetration to abdominal cavity or not. If there is posterior trauma, step wounds, also we follow patient 48 hours with physical examination, blood CT, and different from the thoracoabdominal, we do IVP and, if necessary, colonoscopy. After this examination, if there is a positive signs of peritonitis, patient will take patient to operating room. If this is a negative for thoracoabdominal, we check this is the right side or the left side. It is different. If it is the right side in my clinic, we send this patient to the home. If it is the left side, we concern about the diaphragmatic injury. So for this patient, after 24 hours, we do diagnostic laparoscopy for evaluation of diaphragm. For anterior, after local bore exploration, if there is penetrating or non-penetrating wound. And then if there is non-penetrating wound, we send this patient directly from the emergency room to the home. If there is penetrating, then we start do this like this kind of diagnosis. If the patient has posterior trauma, after evaluation, if there is no any indication for surgery, which send this patient to the home. If the patient hemodynamic is stable, but you are not certain patient has peritonitis or not, sometimes you observe patient like this. We cannot say 100% patient has peritonitis and 100% patient has no peritonitis. For this patient, in my clinic, we do diagnostic laparoscopy. If the patient have hemodynamic unstable, or if the patient findings of peritonitis, or if there is organ evisceration or the patient unconsciousness, we take this patient directly to the operating room, do laparotomy. You see the whole algorithm here together. This algorithm in 2012 published in European Trauma and Emergency Journal. Now our result. Between April 2009 and 2014, you had 355 cases, most of them anterior, 200 cases, thoracoabdominal nearly 100 cases, thoracoabdominal and anterior both 21, and posterior trauma 24 cases. For anterior, 60 patients, 28% underwent laparotomy, and other 153, 71% we managed non-operatively without laparotomy. In laparotomy group, we classify urgent, early, late. This means urgent when patient reach the emergency room, and if you take the directly to operating room, this is urgent. If in 24 hours they get the patient to operating room, this is early. After 24 hours, if you get the patient, this is late. You see, 25% underwent urgent laparotomy, 70% therapeutic, 2 negative, and 2 non-therapeutic. Just I want to mention here, you see, patient come to emergency, we decide the urgent laparotomy, still 4 of this patient had negative laparotomy. In early group, 42%, therapeutic laparotomy 19, and non-therapeutic even 6. And in the late group, therapeutic 12, non-therapeutic, and 2 patients had non-therapeutic, and negative laparotomy. You see, after all evaluations still, we have negative laparotomy and non-therapeutic laparotomy. How about thoracoabdominal trauma? We have nearly 100 cases, thoracoabdominal, right side 12, and left side 85 cases. In right side, one patient need laparotomy and other 91% treated non-operatively. In left side, 6 patients under laparotomy, 79% non-laparotomy. Even you see here, in this laparotomy group still, we have 4 non-therapeutic laparotomy. Other cases underwent diagnostic laparoscopy. We found 13 patients with diaphragmatic injury and nearly 20 patients didn't accept the diagnostic laparoscopy for evaluation of the diaphragm. If we look thoracoabdominal and anterior trauma, 21 patients, the 33% under laparotomy and 67 non-therapeutic treatment. And also you see here, 2 patients died in this group. How about the posterior trauma? 24 patients with posterior trauma, all of them managed with non-operative treatment. Altogether, more than 350 cases, nearly 300 of them treated conservatively, 74 laparotomy, mortality 7. In the laparotomy group, therapeutic 62, non-therapeutic and negative laparotomy, more than 10 cases. How about diaphragm injury? In this series, our diaphragm injury rate, 23%. How about morbidity and mortality for these cases? We have 9.5% mortality and also 9 to 5% morbidity. And in the conservative group, no morbidity and mortality occurred. And all patients who died, who expired in emergency laparotomy, this means laparotomy done in 24 hours. How about the complication? We have wound complication, intra-abdominal abscess, incisional hernia, biliary fistula, wound infection, and abscess, and also again biliary fistula. As a result of this study, I can conclude like this. The majority of general surgeons working in the emergency unit were not previously trained in selective non-operative management like our country. Surgical residency programs differ with regards to the education given as well as training to hospital in which the residents take place. Before January 2009, in my unit, the rate of negative laparotomy was 55%. There was a high rate of negative and non-therapeutic laparotomy due to the fact that the emergent management of trauma remained the responsibility of general surgeons who were unfamiliar with the selective non-operative management. In order to decrease the rate of negative laparotomy and misdiagnosis, an institutional algorithm, each institution according their infrastructure and resources should produce their own algorithm. And surgeons without experience in selective non-operative management prefer to perform exploratory laparotomy to minimize the delay in diagnosis. However, after a standardized specific algorithm was implemented, conservative treatment has been shown to be effective for step wound patients. Lastly, this study demonstrates that process of success of implementation and algorithm for the management of penetrating abdominal step wound injury in education and research hospital. I emphasize on this. This will be implemented at university hospital of training and research hospital. You cannot implement this algorithm in a small clinic that where only one surgeon or 2 surgeons work. because you should follow this patient very close during the night and during the day. This algorithm justifies the accuracy, reliability, and safety of selective non-operative management of hemodynamically stable patient. Selective non-operative treatment, which has been the standard practice in many trauma centers during the past 50 years, may be performed with caution in well-equipped medical center with well-trained staff. Thank you very much for your attention.
Thank you, Dr.
Thank you, Dr. Orhan. Our next presentation will be from Dr. Murat, an emergency physician from Jalal Bayer University. He'll be discussing pelvic trauma.
Assalamu alaikum. I talk about briefly pelvic injuries. Pelvic injuries often represent multi-system injuries. Hip fracture are common in elderly osteoporotic patients after falls, and in younger patients, hip and femur fracture are usually due to violent mechanism. Pelvic major trauma mechanism is motor vehicle crashes, falls, and direct crash of pelvis. And pelvic fracture are associated with a high morbidity and mortality because of the large force required to fracture the bony pelvis and the concomitant abdominal, thoracic, and heat injuries, and the possibility of major hemorrhagic loss from highly vascular pelvis bones. Increasing pelvic volume allows for increasing hemorrhagia, conversely reducing pelvis volume reduces potential for bleeding by realignment of broken bone ends. And the arteries most frequently injured are the iliolumbar artery, the superior gluteal and internal pudendal artery. And clinical features, pelvic fracture should be suspect whenever there is trauma to the torso or a fall from a height, and pain, crepitus, or instability on palpation of the pelvis suggests the fracture. And clinical assessment of the pelvis includes observation for physical injuries such as bruising, bleeding, deformity or swelling to the pelvis, shortening of a lower limb may be present. And the other clinical features, perineal or genital ecchymosis or hematoma may be observed, and in case in which many hours have elapsed since the injury. And ecchymosis in the periumbilical area or flanks from retroperitoneal hemorrhage may be present. In CT, seen on retroperitoneal hemorrhagia. And hematoma over the inguinal ligament or perineum, gross hematuria or vaginal or rectal bleeding should increase suspicion. Hypotension may be secondary to abdominal or thoracic injuries or blood loss from disrupted pelvic bones or vessel. And degree of hemorrhage dependent on fracture type, truly massive in large posterior fracture, and retroperitoneum can accommodate large amount of blood. And direct open operative treatment seldom, if ever, indicate unless major vascular injury uncontrolled after angiography. Diagnosis, radiography confirm suspect pelvic fracture. The AP pelvic film is the most useful. And APV can be used as screening study. Other film chooses on previous slide can then be ordered based on findings on the APV. And should obtain in all major truncal trauma cases with any abdominal pain or findings patients with hip pain. And the other choose computed tomography. Computed tomography provides more detailed information in pelvic fracture. Additional indication for pelvic films for trauma patient, ecchymosis or tenderness over any pelvic bone, joint pain, and abnormal rectal exam, and abnormal lower extremity urinary exam, and blood at retrialmia or hematuria. Injuries to other organ systems are extremely common in patients with pelvic fracture. It's important to identify all major injuries to other organ system to prioritize definite surgical treatment for the multiple traumatization. In women, it's important to consider the possibility of pregnancy. Immediate sequelae of pelvic trauma, massive hemorrhagia, bone disruption of pelvis and vascular interruption, urologic injury, bowel and vaginal tears, and neurologic injury. Many classification for pelvic trauma exist, especially the young system is helpful because classification are based on mechanism and directional force and predict the likelihood of severe hemorrhagia. In young system, the forces of compression is anterior-posterior compression, combination mechanism, and lateral compression, and vertical shear distinguished characteristic. In emergency care and disposition, standard protocols for evolution and stabilization of trauma patients should be initiated. A careful search for other significant injuries should be made because there is strong association with other major injuries. Access to airway, breathing, and circulation, and mini neurological exam. Evaluate whether patient is time critical or night time critical, following criteria as per trauma emergency guideline. If patient is time critical, correct airway and breathing problems is important, and stabilize the pelvis on scan and repeatedly transport to hospital. And assessment by compression or distraction springing of the pelvis is unreliable and may both dislodge clots and exacerbate any injury and should not be performed. And in emergency care, emergency department care, patients should receive oxygen and cardiac monitoring, 2 large bore IV line, and blood should be sent for type and cross matching. And hypotension should be treated aggressively, fluid treatment, and packet red blood cell. If the pelvis is unstable, it should be wrapped circumferentially with a bed sheet that is pulled to provide enough tension to reduce pelvic volume and stem hemorrhagia. If the pelvis is unstable, an orthopedic surgeon should be consulted early and to provide external fixation for persistent hemodynamic instability. Angiography for embolization of pelvic vessel is another option with continued major blood loss. And intra-abdominal solid organ injuries and other sources of blood loss should be considered. If diagnostic peritoneal lavage is performed, a supraumbilical approach should be taken to avoid disruption of pelvic hematoma. And if the pelvis is unstable, a Foley catheter should not be placed in males if retroviral injury is suspected until a retrogram is performed. In stable pelvic and bone fracture, avulsion fracture involves a single bone that is avulsed during forceful muscular contraction. And pain management, pain should be managed appropriately, and analgesia in form of opioids and morphine sulfate may be appropriate. And other opioids such as fentanyl or midazolam. And angiography with therapeutic embolization of bleeding arteries is more effective than takes precedence over invasive external fixation. And summary goals in ED management: 1, resuscitation; 2, recognition; and 3, evaluation, identify associated non-pelvic injuries, especially head, chest, and intra-abdominal in patients with pelvic fracture; and stabilization, wrapping the pelvis in a sheet and towel clamps in the easiest way to immobilize the pelvis. 5, control of bleeding. Angiography is highly effective in treating pelvic arterial hemorrhagia. Pelvic packing during laparotomy is another way of control bleeding, and institutional practice determine if one or both technique are used. Thank you.
Thank you. Our next speaker will be Professor Akif Karagosis, Professor of Orthopedic Spinal Arthroplasty, Baltimani Teaching Hospital in Istanbul. Welcome. He will talk about surgical treatment of femoral neck fracture.
Assalamu alaikum. Good afternoon, ladies and gentlemen. First of all, I am very happy to be here again. And also, thank you very much to Dr. Supi and Alimoğlu to invite us here. This nice and beautiful congress. Now, my topic is femoral neck fractures. Femoral neck fractures is common in elderly patients. Is a big problem our modern society. Also, challenge in decision making about exact and good treatment this kind of problem. Now, I'd like to show you something about vascularization of proximal femur, because it's a some special thing about vascularization of this part of body. A major source of the femoral head, you can see here, medial femoral circumflex artery, and second intramedullary vessels, and the third ligamentum teres artery. During the fracture, nearly 40% of the cases, medial femoral circumflex artery may be damaged or ruptured. This is important artery to bleeding femoral head. After the fracture, maybe a high percentage of the avascular necrosis of the femoral head or non-union. Also, another important thing is neck of the femur has no cambium layer. That means during the control of the patient after surgery on X-ray, maybe a surgeon don't see much union around there. Mechanism of injury. Most of the fracture occur standing position. Excuse me. Fall standing height. Nearly 40 or 45% of the cases falling from standing height. You can see on the slide nearly 40% of the falling from standing height, and also 21% of motor vehicle accident. some epidemiologic point of view. You can see on the slide, intracapsular fractures, nearly 50% of the femoral neck fractures. Also, 80% of the femoral neck fractures are osteoporotic male or female patients. But in young males, more likely to occur following a high energy trauma. In our institution, we evaluate a total 377 cases, 167 male, to 10 female. Also, some associating fractures during the femoral neck fractures. For example, proximal humerus fractures and also wrist fractures, also accompanying with femoral neck fractures. Also, some associating pathology as in elder population. 70% of elder patient ASA 3 or 4 points. Also, they have some acute myocardial problems or cerebrovascular diseases, diabetes, something like that. Also, 25 or 30%, some cognitive disorders. And most important thing is osteoporosis. Also, some associating problem in younger population: alcohol use, steroid, renal insufficiency, rheumatoid arthritis, or some endocrine disorders they have. Now, we look together classification system femoral neck fractures. We have different kind of classification system. One of them is anatomical. You can see here subcapital, transcervical or basocervical fracture may occur. Second and most usable classification system is a Gardner system regarding trabecular alignment of the femoral head and neck with acetabulum. You can see here trabecular alignment. And the third classification system is a Powers. Powers system is a angle of the fracture line. It may be 30, between 30, 50 or 50 degrees to vertical line. Treatment modality, choosing the displacement amount of fracture, age of patient, the time elapsed following trauma, and the most important, osteoporosis and displacement and age of patient. Three of them more important than the other to choose treatment modality. Now, how can we treat femoral neck fractures? One way for the non-displacement fracture, but
Could I ask that everybody keep their conversations down? If you feel the need to talk, please step out of the room. Thank you. Please keep your conversations down.
لو سمحتوا يا اخواننا، يعني عمال بحكي وبرضه ناس بيتكلموا مش سامعين، احنا هنا مش سامعين ايش بحكي. لو سمحتوا بس النص ساعه تحملونا وخلاص. شكرا.
Now, one way to treat femoral neck fractures is a conservative way, but we have limited cases because 15% of the cases only non-displaced. And the other way, internal fixation is a big part of our profession, treat for the femoral neck fractures. If you can do correctly an internal fixation method, nearly 90% union rates occur. Also, you can see internal fixation way with minimally invasive technique. You can see here is a case example. Young patient, non-displaced femoral neck fractures. We use cannulated minimally invasive screws. Is the another example, and another way to treat femoral neck fractures is a hemiarthroplasty. Now we have modern design. You can see here hemiarthroplasty. Also 70% excellent or good outcomes will occur. You can see a sample, case example, 80 years old osteoporotic female patient, treated, cemented hemiarthroplasty. You can see here. Yes, and most of the cases we can do arthroplasty. I show you some example also. Excuse me. Yeah, this is femoral neck fracture, 63-year-old male patient. We treated with total arthroplasty. Okay. Total hip arthroplasty requires longer surgery time and bleeding, expensive technique, but have better functional outcomes. And conclusions, treatment of the femoral neck fractures still challenging in decision making. In young patients, internal fixation are primary way. Elder patients can choose arthroplasty. Thank you very much.
Thank you. Our next presentation will be Dr. Riyad. He's a consultant surgeon and the head of the surgical department at Beit Hanun Hospital. His presentation is entitled Survival Improvement for Patients with Severe Pelvic Injuries in Gaza, Damage Control versus Definitive Surgery.
Assalamu alaikum. Allah ya'طيك العافية. Bismillah ar-Rahman ar-Rahim. I'll talk today about the damage control surgery. We have heard previous lectures about this, but we want to see what's happening in our society or in our war surgery, especially in Gaza. And everyone knows in this world that Gaza has been exposed since the last 15 years to many horrendous wars and invasions. And these wars has moved the whole Palestinian society to change its mode of caring for patients. So that I think the governmental, non-governmental, and all people move towards opening more hospitals and deposing more surgeons and trainees in general surgery to cope with the problems and the high numbers of injured through these wars. So it was a big challenge for all the Palestinians, especially the surgeons, how to cope with this problem, how to counteract this immense number of wounded and massive injured patients who were in normal situation. You will not have these conditions that you see on one time, as well as you see that these patients are injured not in one place, like the abdomen or head. They have been injured by massive destruction weapons in whole the body, so that the abdomen itself also has multiplicity of organs injured. And this multiplicity of injured organs and the destruction in the whole abdomen makes the mortality rate very high. So how can surgery save this problem? And I think the main problem in the mortality appears in that these patients have the main triad that brings the mortality higher is the hypothermia, the acidosis, the coagulopathy, which are the main determining factors or pathophysiologic factors that can carry higher number, or if they carry on these problems, these pathophysiological problems, and so we have to stop it. So many surgeons, since about 30 years, have been working in this and have evolved some solutions to counteract this problem and to listen from the problems of this scenario. So one useful technique was how to control this damage. It's the damage control laparotomy or surgery. And many people, starting in the USA and Europe, have written about this and came to the conclusion that if we use this damage control surgery, we can increase the survival rate and we will abbreviate the time of surgery. Abbreviation of time of surgery is here very crucial in Gaza because we receive on one time a lot of patients, overcome the number of or the surgeons who exercise the surgery on one moment can't do the whole surgery for these whole patients. So the time factor is here a determining factor and should be studied thoroughly and documented also thoroughly. So the outcome of these severely injured patients can be decreased by the damage control surgery when it is used properly. But how can we use it properly if the knowledge of this is not in war surgery especially? There is some knowledge of this is already in the literature about the damage control surgery when it is used not in war situation. But in war surgery, there is no randomized clinical controlled study in order to come up with some results. We try to make this and to understand what's the damage control surgery, and it starts that the initial management should be started by the initial laparotomy, which is the damage control laparotomy that is timely, should be abbreviated, short, and done under emergency conditions so that to stop the bleeding mainly or to stop the main insulting problem in the body and to close the abdomen temporarily. The second thing is after that is to continue the resuscitation and to correct the pathophysiologic derangements that happens in these people. And finally, when they are suitable for definitive surgery, to carry them again to the theater and to close their wounds on their abdomen. So in the first stage, the control of hemorrhage and the control of contamination should be as quick as possible, and then to close the abdomen temporarily. And the optimal strategy for this closure of the abdomen should be properly in order to prevent evisceration and to evacuate the fluid thoroughly, allow the access to the abdomen again and again, and allow the expansion in order to prevent the increased intra-abdominal pressure, which can be also comorbid and could carry a higher rate of complication. In the second stage, we have to carry on in the ICU management, the aggressive correction of fluid and the aggressive correction of the acid-base balance and the coagulopathy. The third stage is after restoration of the normal physiology of these patients has to be the reoperation for the definitive closure of the abdomen and the reconstruction of the abdomen or in subsequent operations if necessary. The problem in what can be a negative factor for the damage control surgery in war surgery in order to save time while packing the abdomen with a lot of packs, and this can increase the intra-abdominal pressure, and this will worsen the outcome. Also, if the abdominal injury is accompanied by other injuries, like thoraco-abdominal or other injuries of the limbs or burn, like what we have seen through the missile injuries, which we seen through the wars. And very important is to emphasize when to use the damage control surgery. This is the indication for this has to be defined, and we will see this on the figures later on. But before entering the operating room, it is better if the surgeon knows primarily, will he go for damage control surgery primarily, or will he go for primary definitive surgery? Because this will shorten the time if your decision is primarily made. And in trauma patients, the relative preoperative indication for many trauma centers have set some figures that the systolic pressure should be below 90 with massive abdominal injury. Now, if we have here in war-injured patients difficulties in collecting data, we should not neglect the importance of the war-injured data and even the photos or pictures or videos of these patients, because the review of these data can give us good hints later on about how to conclude for damage control or not. And the available data actually are more or less statistical data or quantitative, but qualitative data are hardly to find. And the available records of these data about war wounded, mostly if you find some operative notes or X-ray or CT notes, you will find them poor because they are done quickly because of the short of time that the surgeons face in that moment. So the documentation could be short because of the war conditions. It is not a shame to have a paper like this written by the hand about some patients who have lived on the still surviving major pelvic abdominal injury. This is by the handwritten. Maybe I called it a direct data extraction sheet. We don't need to call for the old file, maybe in war conditions, in order to see what happened to this patient. Maybe it is worthwhile. Maybe I recommend to put some notes for each surgeon for the patients who has operated on, and to keep them and maybe to use them later on for follow-up till we have some sort of standard papers that can we use in our files to document and to analyze our data. The difficulties also for these data that they can't be very similar, that to be as numbers to see that they are all only abdominal, only pelvic, only they have bled 10 liters or 5 liters. They are very different. Each patient has difficulties when the similarities to find between the patients are very difficult. We have divided a group of patients that we collected from years of war, about 13 years, collected them and divided them in two groups and find some similarities of them who were abdominopelvic injuries, of course, and all of them missile and gunshot, all of them bled various amounts of bleeding and presenting by shock. The injuries were also combination between multiple organs of the abdomen, starting from the liver and ending in the bladder and major pelvic vessels. The study population is actually the war wounded, and this is from the years what we noticed through the start of the invasion to Gaza up to last year, and we have found that what could we collect from available files, about 65 patients. This number is shortened to as small as 32 because of the similarity between patients. We can't take the 65 patients because some of them have a major burn or injury in the head and so, and this will carry the mortality higher. The injured patients found in young age, they have no comorbid added diseases, diabetes or whatsoever. They are all young, healthy patients injured by the war. Their age is between 14 and 42. The patients in themselves, in spite of the similarity of the injury, also vary in their injuries. The division on two groups, A and B, those who were operated with packing in the abdomen in order to stop the bleeding, to keep them alive, found about 10 patients, and the other 14 patients who were operated for primary definitive surgery and didn't undergo another second lock surgery. The method which we use is retrospectively to study these data. We have, for this reason, also subdivided the two groups in 4 grades or classes according to the severity of injury. Some of them in the upper abdomen, mainly liver, spleen, and small bowel. The second class, including in the first class, plus some colonic injuries, perforations of the colon and so. And the third is colonic, rectal, and bladder. This is mainly pelvic. And the fourth class, which is horrendous class with pelvic injury, with vascular bleeding, either capillary from the bone or main vessels of the pelvis. So the table here shows some data that can we extract from them some conclusions. The first class shows which were only upper abdominal injuries. Here the number of those in group A who were operated by packing of the abdomen. There were 3, and who were not packed, and the mortality rate is low or the same mortality rate. In the second group, also no difference in the mortality rate if you pack the abdomen or not. But in the third group, there is some difference between 62 and 50%. So the difference in packing didn't bring us more advantage. But in the third group, where 10 patients were packed in the abdomen, only 2 died. And in the other group who were not packed, and the trial of primary definitive surgery was done, 4 of them died, only 1 survived. So the other result which we have looked at was the time of surgery. Actually, to define the time of surgery was very difficult, and maybe from the memory of some surgeons or my own memory is to, and this is debatable, but however, we have the impression that it is shorter, about 1 hour shorter in general. And this is between damage control surgery and normal surgery, is when you shorten the time of about 50%, 40% of the time of surgery, you have good chance to save more lives and to do more surgery. So as a result, as we said before, in the first 2 groups, shows that there will be no difference if you indicate packing or not. And in the third group, vaguely, and you can say it could be according to the surgeon's situation and how much patients are available to proceed with the primary surgery or to make the packing. The fourth group with the remarkable improvement compared with the without packing. So the damage control surgery can't be justified through this result as a conclusion, and if the bleeding or the main damage in the upper abdomen but it is fully justified or according mainly to the situation in which the surgeon is exercising the problem here. And the recommendation also is the damage control surgery should be for trauma, explosive, or acute general surgical problem in severely injured patients with acidosis, hypothermia, coagulopathy, prolonged hypotension. If the packing is used, we recommend not to remove the pack before 24 hours. Here we have some experience with some people who were operating in the north of Gaza, Kamal Adwan Hospital, and he was shifting with packs in the abdomen to a Shifa hospital. Once the surgeon removed the pack, the patient instability led him to death. So we recommend to the 24 hours of packing in order to give the chance to correct the shock and the hypovolemia. The decision also for damage control surgery should be made in the time of triage or while making the triage for the patients, and in order to save the time. I suggest here that we need multidisciplinary teamwork and training for this type of surgery because we are living in war conditions. We have to stress on war surgery and how to control the problems of the damage control. And the medical reports are medical also files, including this operative notes, to be more accurate and to determine the problem and to get to the point of the problem during the surgery and to put it on notes so that we can later on look at and review it, make some studies of them in order to elevate the level of the war surgery. And this is, I think, a burden of every side from the people who are listening now, including the ministry, governmental, non-governmental, even the people who are training for board, that the surgery is not only to do the surgery alone. We have seen here in many lectures that sometimes non-operative conservative surgery, very important. And so we have to do more effort in doing the knowledge of notes more effective. Thank you very much.
Thank you, Dr. Wright. Shukran, Dr. Wright. Our next speaker will be one of our young surgeons who will have the future of Palestine surgeons. He will talk, and he participated taking care of casualties at Shifa Hospital. Dr. Karam Slaby, he will talk to us about type of injuries and outcome, the surgical experience of Shifa Medical Complex and management of abdominal war injuries during the war on Gaza. Please, but we are limited in time, please.
Okay. Assalamu alaikum. Today, let's talk about the surgical experience of Shifa Medical Complex and management of abdominal war injuries during the war on Gaza in July 2014. At first, I would like to thank my colleagues, Dr. Hilal al-Sheikh, who helped me in data collection, and Dr. Ayman al-Sir, who participate in statistical analysis. And I would like to mention a special thanks for Dr. Marwan Abu Sada, who helped me in statistical analysis and who was the supervisor of our work, who gave us a total support. Okay. Today I'll give an introduction to our work. Then I will talk about the objectives of our study, methodology, results, and I'll compare our work with others in order to give our recommendation. Next, please. A history declares that we are in an area of frequent wars in a short period of time. As we know, Al-Nakba started in 1948. Then the first Intifada was in 1987. The second Intifada was in 2000 and In 2009, we faced Battle of Al Furqan. In 2012, Battle of Hijarat al-Sijil. And recently in 2014, we faced Battle of Al-Asf al-Ma'kul. From this history, we can conclude that just in the last 6 years, we faced 3 wars. That means we faced there is a war every 2 years. Who knows in the coming years what will happen? Who knows? Especially from the statistics here, we notice that the number of martyrs and the number of injured people, even the number of work days are increasing or even duplicated. All these things lead us to prepare this work to our general objective, which is to evaluate the management of patients who were admitted to general surgery department during this war. The specific objectives were to identify the statistical data behind the admitted cases during this war and to illustrate the experience of general surgeons at Shifa Medical Complex and comparing our results with international studies. Actually, we spent a long time to prepare this work, starting from archive. This is my colleague, Dr. Hilal, and then in statistical analysis, and this is Dr. Marwan Abu Sada, and I'll tell you how we did that. First of all, we did data collection for injured people. We found that the total number of injury was 10,870. About 41 of these number have treated initially in the Shifa Medical Complex, and about 1,800 have been admitted to the hospital. About 1,000 surgery have been done in Shifa Medical Complex in different specialty. From them, 112 surgery, especially in abdominal injury, and 712 patients have been treated conservatively, and 37 patients from them due to abdominal injury mainly. So that means we have studied 149 cases. We did a statistical analysis for these cases in a retrospective way. We analyzed their gender, age group, mechanism of injury, length of hospital stay, usage of image modality, rate and type of injured organs, associated injured organs, complication management, and mortality rate. And we compare our work with others in order to give our recommendation. Our results, we found that the male injury was in about 73% of cases, and female injury in about 27%, and this is expected ratio, but the unexpected was the high number of percentage of female injury. We talk about 27%, and this reflects the severity of this war, how dirty it was. When bombing the civilians in their homes, in their schools, even in their hospitals, such as what happened in Shuhada Al-Aqsa Hospital in the last war. And the shocking was about half of the injured people were children. We talk about 41% of the injured people were less than 18 years old. About the mechanism of injury, explosive injury was extremely high. About 97% were due to explosive injury. The length of hospital stay, the mean was 5 days with a standard deviation 4.7, putting on mind that some cases have been referred to other medical centers. Of course, the cause of referral was due to shortage capacity of Shifa Medical Complex during this crazy war. The usage of image modality first was done in about 89% of cases, and about 13% underwent CT scan. when the depth of injury was in doubt and when the equivocal clinical signs occurred. A total number of laparotomies was 112, and about 83% of them was positive exploration. The comparison between the injured structure revealed that the large bowel, small bowel, and liver were the most common injured organs. And this is expected due to the fact that this number occupy a large portion of the peritoneal cavity. Comes next splenic injury with 12%, and the shocking again was diaphragmatic injury in about 10%. And this was due to shrapnel, which can cause immediate perforation. Also in our study, we found that about 50% of cases had more than one organ injured. About the associated injured organs, the limbs were in the top of the list, with a slight difference between upper and lower limbs, given the opportunity to lower limb with rate of about 30%. The lowest percentage was associated pelvis injury in about 10%. In management, splenectomy was done in about 77%, and liver repair was done in about, in almost all of the cases. We talk about 90%, and bowel repair was done in about 71%, whether in small or large bowel. About the complication, a 6 months follow-up for these cases revealed that the wound infection was the most common complication, in 6 cases only. And comes next intestinal obstruction, wound dehiscence, and re-exploration. The mortality rate for these cases was 16.1, and the leading cause of mortality was due to associated head injury in 7 cases. The other causes was cardiopulmonary arrest post-op in ICU, and hemorrhagic shock, severe burn with metabolic disorder, and septicemia. In fact, I remember one of the case where died from hemorrhagic shock was due to single gunshot starting from supraclavicular area, lead to fracture to the clavicle, and pericardial injury, apex of the lung injury, pericardial injury, diaphragmatic injury, stomach injury, and body of pancreas injury, and renal vessels injury, and the bullet settled in his vertebra, and the patient died intraoperatively due to multiple organs injury. In this table, we evaluate our work with others. By comparing our number and our results with with what happened in other area, in other hot area of the world, in Sarajevo, in Uganda, in Gaza, and in Bosnia, in Gaza after the second intifada. In general, we found that the number of patients in relation to the duration of war was the highest in our study. For comparison, in Sarajevo, the number of patients was 273 in about 7 months. But in our study, there was 149 patients in just 51 days. And this reflects, as I mentioned, for the severity of this war. The other thing was the most common injured organ in our study was large bowel, and in the rest of the study was small bowel, where the main mechanism of injury was gunshot. About the mortality rate, our result is close to the international standard, and the leading cause of death was due to associated hemorrhagic shock, but in the rest of the studies was due to hemorrhagic shock. And by the way, from all the cases that we have been studied, only 9 cases have a pure abdominal injury. The others have associated injured organs. And the most common complication was wound infection. All the study with low rate in our area for less than 5%. Also, we can conclude from lecture of Dr. Ogul اليوم today. Yes, mentioned that in Turkish, the 5 years firearm revealed that the total number of patients was 48 in 5 years, and the small bowel was the most common injured organs, and the mortality rate was about 10%. From this table, we can conclude that our experience is very comparable with international standard. And this is the abstract of the paper that we have compared with. In conclusion, explosive injury was the most common type of mechanism of injury in about 97%, and 41% of injured were children. We found that different abdominal organs were encountered in this war, and the large intestine were the commonest viscera injured with rate of 24%. Shrapnel was the leading cause of abdominal injury following terrorist bombings, and we can conclude that our surgical experience in Shifa Medical Complex is fairly comparable with international standard as regard management, complication, and mortality rate. Finally, our recommendation to improve our triage system, we suggest to make a fixed triage team, and we need to frequent training courses for all staff of the hospital, not only surgeons. Because we treated many patients in the last war on the stairs, on the floor, we need more beds and medical equipment and operative rooms. And finally, the most important recommendation to avoid all of this, to stop war, please. Thank you.
Thank you. We had JD, the head of the ICU at Shifa Medical Center, and he will be giving our last presentation of the conference. Type of injuries and outcomes of critically ill patients who were admitted to the ICU at Shifa Complex during the war on Gaza, 2014.
بسم الله الرحمن الرحيم. السلام عليكم. إن شاء الله ما نطولش عليكم. We have started with Gaza war, and we are ending with Gaza war. This is because our situation and with its tragic impact. This study was done by me and Dr. Jihad Jaidi. He is our ICU Shifa Hospital, head of ICU Shifa Hospital. No? هذا طيب. Objective: to determine the number of total injury, their categorization, type of injuries, and their outcome. Methodology: it was a descriptive study, encountered all patients that entered ICU, categorized according to demographic variables, type of injuries, and their outcome. I don't like to repeat this figure, but I want to focus that the dead cases which admitted already to the hospital, 60 patients. Among all the deaths that has been dealt with in Shifa Hospital, that reflects the aggressive and fatal nature of these injuries. Among those patients, 51 patients died in ICU. Again, total number of injured patients, more than 10,000. The admitted cases in the hospital, about 1,800. Among those admitted, 253 patients in ICU. The percent is too small, about 14% who was admitted to ICU, compared with the last war, Al-Furqan, 2008. It was 28%. This was because we are doing triage. We have little resources in the hospital. We have little beds. We are in ICU 11 beds, expanded to 33 beds among during the war, over 5 units over the hospital. So 3 times expanded, 11 beds to 33 beds. But the staff is not, because the nurses and physicians only expanded below 2 times. This is shortage of team. That's why we're sorting out the cases that, because we have our facilities is limited, and that explains the relatively high mortality rate, about 20%. International figures shows that ICU patients 10 to 20% has mortality rate. We among the last year 2014 we have 10% the whole year, but during the war we have 20% mortality. That was explained by the aggressiveness of the severity of these patients. This was showing about 1/4 of the cases that admitted in ICU the last year was during the Gaza war. Over than 1,000 of cases admitted over the last year. 1/4 of them are admitted only over 51 days. That shows that this was severe cases, and turnover admission rate was high. Distribution of patients according to age group who was admitted to ICU. We show that about 1/3 of patients are younger than 15 years. And according to gender, we show that about 58 patients who are female. That means that about 1/4 of the ICU patients were female. And this again reflects that there was no preservation to the gender, no preservation to the age group. This is the type of injuries. As we see, there are many types of injury: traumatic brain injury, chest, orthopedic, abdominal, maxillofacial, burn. This was all. And of course, there are polytraumatized over than 1/2 of the patients. There was overlapping injuries, of course. This is two group categories. As we see, polytraumatized patient, there were 140, about over 1/2 of the patients who was admitted to ICU. Among them, over 1/2 of the patients who had traumatic brain injury, 128 patients. Mortality rate was 1/5, about 20% of all traumatic brain injury died. The second frequent cases was thoracic injuries, 75 thoracic injuries, and mortality again about 1/5. Orthopedic cases are also still high. Abdominal, as we see, there are many types of injuries, and there was overlapping. Polytrauma constitute that more than 1/2 of the admitted cases. Next, please. About 20% of death. This is among admission. Next. The same figure. Next. Next. This figure shows that the referred case outside, that was for evacuation. As I said, we have limited beds. So about 38 patients of the admitted cases, about 20% of the admitted cases in the ICU was referred. Also, it's little number compared with the last war, Furqan 2008. It was 40% of the ICU cases. Now 20%. This is the distribution of different areas: Egypt and Jordan and West Bank. Next. This shows the total number referred 38, about 20%. Next. The main cause of death, as the study concluded, traumatic brain injury. It was 51% total deaths ICU. 26 had traumatic brain injury, and 13 patients died from isolated head trauma, and 13 other died with traumatic brain injury. Conclusion, 1/5 of patients admitted, of all total admitted cases, 1/3 of them were child under 15-year-old, 1/4 were females. The most frequent and most serious cases was traumatic brain injury, followed by thoracic injuries. More than half of these patients who had polytrauma, mortality rate 20%. About 20% was referred abroad or other hospital. Next. We recommend briefly 3 points, 3 words, that we have to expand our team, nurse and physician, cleaners, radiotherapists, and all this staff, to expand the beds in the hospital, especially in our situation, and to emphasize, empower more and more team working. Next, last slide. Last slide, final word. The key of success is emphasizing and empowering the multidisciplinary approach of the multiply injured patients, the collaborative efforts of all teams and staffs, keeping lines of communication available around the clock, and the using of limited resources judiciously. Thank you.
Thank you. That concludes our presentations. We will have 5 to 10 minutes for questions and discussion. Are there any questions?
طول مايكروفون. تسأل في ميكروفون وين؟ خذ اعطي لي اياه هذا. خلاص تمام.
Thank you for nice lectures. The first question for Dr. Orhan. If we have a patient with hemorrhagic shock associated with retroperitoneal hemorrhage, how could you manage the patient to stabilize brain perfusion? This is the first one.
Yes, about the transmission.
I am talking about the patients who unstable, vitally unstable patients from hemorrhagic shock, and the resuscitation is not enough.
Okay.
You will answer now, yeah?
Yes, okay, I understand your question. When patient reach the emergency department, we will open the large vein, start resuscitation. In 15 minutes, we will give 1,000 crystalloid. And meanwhile, we find the blood and we take patient directly to operating room, make laparotomy.
Okay, thank you. The second question. How many patients had you done for him aortic clamping, even if there was no significant vessel injury? Furthermore, we have a huge parenchymal injury in multi-hemorrhagic areas. If we have multi-parenchymal injury, okay, in huge hemorrhagic and huge hemorrhagic areas, how many aortic clamping you do? Why I am talking about that? Because it is very important for me. We saved a life of 3 patients. The first one in this war, supraceliac injury, and we clamp the aorta infraphrenic area. The second one, severe pelvic injury, iliac vein, iliac artery injury, and the aorta was clamped below the renal arteries. The third one, suprarenal clamping, and was nephrectomy done because we show that there are injury of the left renal artery, left renal vein. So we keep alive, after Allah, of 3 patients from the aortic clamping. Why you didn't talk about this very important moment in your lecture?
Well, I think our patient is different to your patient because our injury is civilian injury. It is not so heavy injury, but injury patient here, they are really severe injury. For this kind patient, I think we start to make damage control surgery first, then the definitive surgery. Aortic clamping we are using very, very rare, very, very rare.
في أي أسئلة تانية يا جماعة؟ عشان في
اتكلم ممكن اتكلم؟
لو سمحتوا بس في شوية بسرعة لو سؤال واحد وماشي. سؤال صوتك بيمشي. Yes.
Above 65 to keep, and start with small volume. That means you can start with 250, 300, not start as we are usually doing. In the past was 20 cc per kilogram, then another 20 cc, and another 10 cc from colloid. Damage control station said there is no difference between if you start blood or normal saline. In the past, we know that we should start with normal saline because the vessels is constricted and also. But now said you can start directly with, but don't start fluid association without stopping, as you mentioned, the source of bleeding, because volume and crystalloid or colloid will keep triad, fatal, hypothermia, acidosis, and so on and so on. So the first things to stop bleeding, then to start give small volume according to mean arterial pressure. The second things which shows this damage control resuscitation, which is of course the part of damage control surgery, give a ratio 1 bacterial species, 1 FFP, and 1 platelets. We should not forget this. Even if we give just 1 bacterial species, we should give. The third things, hypothermia starts from avoid not to rewarming the patient or rewarming fluid. Don't worry falling in the first resuscitation. Just avoid hypothermia by getting off clothes and all these things. And that's all. Thanks you very
المرة
much.
الجاية أعطي محاضرة أنت عن الموضوع.
I have done before
شكرا
this.
شكرا. تفضل دكتور. آخر سؤال. آخر سؤال.
To the orthopedic surgeon. You talk about the fracture of neck femur. I am asking about the young patients whom are around 15 years old, especially about the subcapital or transcervical fracture. It is common complication is avascular necrosis. How many cases did you face of avascular necrosis and how you deal with these cases?
If you treat any neck fractures patient, you use some cannulated screw or or sliding plates. It's okay, but in the future, during the follow-up, you see some complication. Some non-union and also avascular necrosis, something like that. In that situation, important thing is the quality of life and what is the function of the patient during daily life. Feel pain, or some difficulties during walking, something like that, okay? If any problem in the future, follow-up time around hip, most of complication is a pain and limping. Okay. Now you change this strategy. If patient younger than 65 years old, you can choose total arthroplasty.
شكرا دكتور اياد على سؤال.
But elder patient, you can choose arthroplasty, but your indication change patient to patient. Sometimes it's necessary to do osteotomy and valgization osteotomy. You can do also. Yeah, yeah, but I don't do any special treatment for the avascular necrosis. Okay.
اوكي شكرا على السؤال. هو we can't stress enough the correction of fluid and the importance of it. I think the best area where the fluid correction should be done is under control in the ICU, under control I mean, because any fluid resuscitation could carry more morbidity exactly for the coagulopathy. So if you correct the fluid, you should consider not only the volume of fluid, but the amount, the quantitative, the quality of the fluid, but also its effects on coagulopathy and acid-base balance. And this is, I think, when you control it by, and as you said, exactly how much you correct. But our main issue in this topic was the surgery itself. The second stage is in the ICU, and this is, I think, we agree with each other.
Thank you, chairman. Thank you, the speakers. Thank you all. Please stay at your seats. We are closing. We will have the declaration of the conference by the presidents of the conference. Then we'll have the closing ceremony. After that, we'll have the lunch. But before that, we'll have a family group picture, photo here. After the end, we'll group here together with the organizing, the president and scientific committee. We'll have a great photo for you and for us. Thank you very much. Doctor. تنزيحها لورا شويه عشان قلت لما اسوي يجوا ناس يكونوا مبينين. اوكي رجعها لورا.